I'd just like to talk today about our ICU on wheels. This is a very sophisticated piece of equipment that we have here today. It's an ambulance which can carry neonatal babies from long distances to tertiary care centers for management, and we can almost do anything in this. It's like a neonatal intensive care on wheels, and it has all the equipment, facilities that a baby will need during transport. The most important thing is that this can transport babies from level 1 or level 2 units safely to a level 3 unit, and it can transport almost all babies having any problems. So this can include babies who are needing cooling, preterm babies, babies needing ventilation, and any pathology, even surgical babies needing surgeries. So that's the most important thing about this thing. So this can travel long distances. In fact, we have done lots of transports from many far off places. It could be all the way from Bidar, Raichur, all the way from Ballari down to Bangalore, where we have transported sick babies. The most important part is that this can accommodate not only a transport incubator, which is a high-end transport incubator, but it also accommodates doctors and nurses and ancillary staff. So the space is quite big, and I will be taking you inside soon and explaining to you about what are the facilities that actually this ambulance can provide. A very sophisticated ambulance. A few hospitals in India have these kind of ambulances, which provides the top-end transport facilities. In fact, this is very similar and is based on the transport incubator that is run by the NHS in England. They have exactly the same type of ambulance with the same facilities. So basically we have named this as NICU on wheels, and I will be taking you inside now to show you about what the facilities that this ambulance can provide. So as you can see, this is a very neatly kept, very modern, transport facility. This type of facility basically should involve, starting with the basic safety equipments. We have a fire extinguisher just in case we need that. Then we also have space for your making sure that all the bin is in place, so that all the used waste can go in there. When we pull this out, it actually can be taken down, and it can be easily wheeled in. So for us, in terms of safety of the babies, it's very easy. So that when the baby is actually there, we don't have to do anything. The ambulance is stationary, so the whole equipment just comes in, and this basically collapses, and then the whole incubator goes inside. Now this is a servo controlled Draeger incubator. This is called Globetrotter. This is one of the best transport incubators that you can actually get. It can carry babies for long distances. It has a lot of facilities. Now the most important facility will be for long-term transfers, long-range transfers, are a ventilator. So this has a ventilator very similar to a ventilator that you can get in a neonatal intensive care. It also can give you CPAP, which is another big advantage if you have to transport babies. So temperature control is there, and which is servo controlled, so that we don't have to keep on checking the baby's temperature. The machine does it, the incubator does it, and it maintains the warmth throughout the journey. So even if it's 8 hours, 7 hours, we have done about 8 to 12 hours transports where this has come in handy and very helpful to us. in addition to the equipments, so you can have a look at there's a lot of space where we can actually keep infusion pumps, so we don't have to actually keep it elsewhere. These are directly connected to the babies, and it is actually helpful. Now the other advantage of this incubator is that it has its own oxygen supply, which will last for a few hours, and we also have our own supply in the ambulance, which basically you can see that we have multiple supplies, which actually can mean that this ambulance has its own huge cylinders, which can actually help us to take these babies for long distances. So the ventilation for us then becomes very easy. The other most important thing is we need a lot of storage spaces, and we need equipments which are actually kept here, and it's very easy for us to access. So if actually when the baby is there, it's very easy. So what happens is when we actually having a baby here, it's very easy for us to access these equipments. If we have to keep anything extra, we can keep here. So there's a lot of storage facilities, and extra ancillary aids can be kept here. So this is a fully air-conditioned environment that we have here, free from outside anything that can happen. So that's the most important advantage we have. In addition to that, to carry appropriate, let's say, people, so we have the equipment in place. We also need the personnel in place. So we have enough space for 4 people, to travel along with this ambulance. And if required, let's say a biomedical person or any assistance is required for transporting the incubator, then there's one more space available at the driver's seat. So that is another big advantage. Sometimes we do 2 drivers if there's long distance journeys, so that the journey is much more easier, and then the fatigue is less, and the transport facilities becomes much easier. So this is the basic things. So again, the cylinders in this ambulance can last a long time. They have a huge capacity, big cylinders inside installed, which basically ensures that there's no scope for supply failure. So that's the other thing. And like I said, they have their own oxygen cylinders which can last for a couple of hours. So the various settings, like I said, they're all server controlled, which check everything, which just switch it on and leave it on, and the whole the incubator just gets heated up like how you get heated up in a neonatal intensive care. We have our own ventilators, CPAP, everything can be given in this, and this is a very, very state-of-the-art transport incubator. One of the consultant then liaises with the consultant who is referring the baby. From there on, we basically plan the transport depending on the condition of the baby, and then the number of doctors and nurses that are required for the transport of that particular baby is then planned, and then we leave in this ambulance with all the equipments in place, and once we reach there, we pick up the baby and come back. Once we come back, we then unload the whole transport incubator along with the baby, and then we take this baby to our neonatal intensive care. So I'm now going to take you to the neonatal intensive care. This is the Center for Neonatology that we have here. As soon as the parent comes, sometimes because this is Corona times, we have provided a bell for them to basically ring so and call for attention. Now there is restricted entry into the neonatal intensive care, but during non-Corona times, parents are usually allowed into the neonatal intensive care, both the mother and the father, and they are allowed to see the babies and handle the babies depending on the condition of the baby. So our neonatal intensive care basically has been designed as per the standard laid out by the NNF. So it has various, just not the neonatal intensive care, but also the various other ancillary aids that are required for the neonatal intensive care. Just to show you around, so we begin our neonatal intensive care with the hand washing that happens here. I'll just take you into our counseling room here, both for the parents as well as for the doctors. To make things easier, we have provided this as a video counseling room. So whatever we talk and say is recorded, so that in case the parents wants to come back later at any part of the discussion or understand things better, then we always go back and show them the video of what has been told, or if they want to just recap things, they can have a look at those videos. If they request, then we'll provide a clip of the video counseling that we do. This is important in today's age, both for the medical legal purposes and also for the effective better patient communication. We are split into on my right side is on an isolation bay. You can see there my colleague along with the nurse doing rounds, looking at the babies there. So we currently have about 3 babies who initially were in the stages of isolation, but we have left them there, though they are currently non-infective. So this is where all our babies who are, say, born to COVID positive mothers or who have any infections, who are referred from outside, do come, and then they'll be here in the initial stages. So as you can see here, this is our isolation. We have about 3 to 4 beds which we can accommodate here, and this is actually a small NICU in itself. And as you can see here, this baby, these are actually 2 twins born at about 32 weeks. This is about 1.2 kilos, and the other one which I'm going to show you is a smaller twin which is born at again the 32 weeks and 900 grams. So this is a bigger baby, that's a smaller baby. This baby has had a lot of issues after being birth. They were actually born to COVID positive mother. Since then, when babies were transferred here, because it was very precious, delivered in a different setup outside the hospital, about 20 minutes away in a COVID center. The mother is doing well currently, but because of the COVID status, she had to be delivered elsewhere. And once the babies were born, our team in a full PPE went there, picked up the babies, transported the babies from there to here, and they were in this isolation baby. There were only these 2 babies. There was no other babies. That the 3rd baby has come in just today, and these babies basically were tested for COVID and have been since tested twice and has been negative. This baby has continued to have problems, very bad respiratory distress, and almost a lot of congenital pneumonia has also been there. Was initially on conventional ventilation, but we since then had to change over to a high frequency ventilation because a very bad X-ray requiring high frequency ventilation. So we do a high frequency ventilation in our unit. As you can see, this baby is currently requiring high frequency ventilation. Is very stable, and hopefully we soon should wean down on the ventilation, and maybe another 12 to 24 hours probably be extubating this baby. Head scans have been normal. Nutrition we are giving to TPN and also some through oral feeds, nasogastric feeds. So this is about this twin. The other twin is basically a smaller twin, but it's about 900 grams. And so as you can see, this baby has not required ventilation and is just on CPAP, has lots of feed intolerance issues, and we are currently managing it as such with total parenteral nutrition and providing appropriate respiratory support. Our nurses are like I said, are very good in terms of managing these babies and updating the doctors. We do have 3 consultants and 1 associate consultant here, and we provide round the care 24/7 service for the babies that do come here. And in terms of the services and the provision, the support, I must say that it is basically continuous support. This baby basically was brought in with a very high bilirubin, and we didn't jump onto the exchange. Was started on triple surface phototherapy, then now is on double surface, and is almost ready for discharge. We're waiting for the blood results, and we expect the blood results to be jaundice test to be normal, and hopefully should be discharged soon with a follow-up appropriate scans and hearing that needs to be done for the babies with very high jaundice levels. So in fact, this baby is a doctor's baby. He himself came in and basically requested us to admit this baby here. It is always an honor for us to treat another colleague's baby because of the trust they show in us, and also it also highlights the standard of care that we provide. So this is about the basic neonatal intensive care that we are doing. It's a level 3, to summarize, it's a level 3 neonatal intensive care wherein we provide almost everything. Once they're cleared of the infection and they are deemed non-infectious, then they go on to the other area, which is what is a slightly bigger area that we have, which is called the clean area or the inborn area. Here we house most of our inborn babies, and we have currently about 12 beds here and about 4 beds there. So totally we have about 16 beds in total. So as you can just generally see, the nurses are along with the babies, getting to different gestations and different pathologies of babies are here currently in our neonatal intensive care. We always have a backup warmer, which is an emergency warmer just in case of emergencies, with all the ports available, oxygen, air and suction, everything is provided. This is basically used as an emergency in case we come across anything all of a sudden that is being delivered on our unit, or if suddenly things go wrong on the postnatal ward and we need to shift the baby for observation. Now, just taking along the babies, as you can see, my nurses are all busy taking care of the babies. So we have different varieties. Now most of this area is basically an intensive care area where we house most of the unwell babies or the sick babies or the babies needing ventilation. And on this side we have more of less intensive babies, though we do manage intensive babies, but these are grouped basically in to help us manage babies better. So if you look at the non-intensive area babies, these are the babies that were in the intensive area and then basically got better and then moved off onto the non-intensive areas. We have a special dedicated crash trolley which basically takes care of all the emergency drugs, equipment that we need in case of any crash that God forbid if it happens. We have everything ready. So all the medications, all the drugs, all the equipments, everything is ready. We just have to pull out the drawers, take out the equipment and then use it for our babies. So here we have a baby who was born at 28 weeks. Now basically went through a stormy course and had pulmonary bleeds requiring high frequency oscillatory ventilation and a lot of feeding issues. So this baby has done well since then and has been extubated now, is about almost 20 days old and is doing well currently on CPAP. So this is one of the babies who had a lot of lung issues, pulmonary bleeding, and we thought it's going to be a challenging baby for us, but the baby has come out well and is really doing well, currently on half feeds and so that the feeding is getting really established well. So we are happy kind of with the progress of this baby. So I'll just take you over to another baby, which is a baby who was born at 26 plus 4 weeks at around 800 grams. This is a very tiny baby, born very early. So for this baby, we basically, when this baby came in, we did an in-short technique, gave surfactant and put the baby on CPAP, and we managed this baby in accordance with the established protocols, good nursing care, and I'm really proud of my nurses. They do fantastic job in taking care of these babies very well, and I must say they provide one of the best nursing care that I have seen. So this baby has been doing really well and has put on a lot of weight and is now basically about 31 weeks old, so has been here for almost 5 weeks now. Fully established feeds, is growing really well, not had any much complications, and this baby is now on what you call as an open care warmer. So basically this baby's this incubator is basically a very high-end incubator. It's a giraffe incubator and it's extremely good for managing very small babies or extreme preterms. It's one of the in my opinion it's one of the really good ones, because this can be converted when you need into an open care warmer. It's the same thing, like because the ports are good, handling is easier, emergencies if we be any can be easily managed with these. So So we have about 2 giraffe ventilators here. As you can see, this is one, and the other one is the previous baby that I showed you. This giraffe incubator. They are really good in terms of helping in managing preterm babies. And I just want to take you over to this one more baby here. This baby is currently on a ventilator, and we are planning for extubation today. This baby was a term baby, but had very bad early onset sepsis, had very bad respiratory distress, and had pneumothorax. In fact, bilateral pneumothorax, as you can see here. This baby has had chest drains inserted, and the chest drains have been removed. Currently the baby is really active, because we are now in a short while going to extubate this baby. This baby has been here for almost about 6 days now, and the baby has done really well. So we are going to take this baby off the ventilator. So basically this baby had bilateral pneumothorax, very bad respiratory distress, and early onset sepsis, treated with antibiotics, bilateral chest drains, and did really well. And now currently we're going to extubate this baby onto CPAP, and then maybe another couple of days this baby will stay in our unit, and will go home soon. This is one of the other pathologies that we manage, pneumothorax problems in term babies. In addition, this baby had a large PDA, and this was treated with ibuprofen. Now we do echo for our extreme preterms on day 3 if they start showing symptoms. This baby did have some symptoms of hemodynamically significant PDA. Was started on ibuprofen, did really well, and has gained weight now. Is currently about 12 days old, and has done a fantastic job of being requiring just Optiflow. This just Optiflow is basically an offshoot of CPAP, where you can see that the baby is just placed on nasal prongs. The babies do really well with that. They don't have to worry. This is a very gentle modality of CPAP. The baby is going to remain on this for quite some more time, and then once the baby does well, we're going to take this off. Baby is going to self-ventilate in air, feeding, and then this baby is just going to be a feeding and growing baby. So this baby, again, like I said, is born at 28 weeks and 880 grams. It's about 11 to 12 days old, doing really well. So this is again intensive care. Here we have most of our babies who have been on to the intensive care area, but then come on to the less intensive area. So we have a baby here who was born again outside, 45 minutes away from here, and was transported here, born at 33 weeks, and is about 1 kilo. So this baby being nursed to make sure that this baby starts establishing feet, gaining weight. 25 weeks, and is about 600 grams. This baby was on the other side, did well, and then came on to this side. Now is currently on CPAP. Otherwise we are not doing much. Fully established feeds, head scans are near normal, and we basically are waiting for this baby to grow. This baby's current weight, sister, what is the current weight?
1.13.
Yeah, so this baby is currently now about 1.13 kilos, and is doing brilliant. Has been with us almost like now about 54 days now. So hopefully this baby should get better soon, put on more weight. Hopefully we lose the CPAP soon, and then can go home. Most of the other babies, again, here we have another baby here who was born at 26 weeks. Is almost hoping, we are just having on Optiflow. So hopefully this baby should soon lose its Optiflow and should be going home in another maybe week time. This is again one of those babies who was born 26 and 900 grams. In fact, this baby the just came out. So the parents just came in, the mother just came in, delivered the baby in the middle of the night. But our team was very well equipped, and so we could go for appropriate resuscitation, surfactant, appropriate preterm care. Was on the intensive care side, and now is currently on to the less intensive side, which basically means this baby is on its way home very soon. If I tell you, we have most of the babies are here are in the range of 31 to 33 weeks, who are born slightly early, in compared to those babies, that are born at around a term. They are in the different weight categories. Some are having phototherapy, some are establishing feeds, but most of these are with very minimal issues, either it be feed intolerance or could be having initial CPAP. Most of them have come off, especially these 4 babies that you can see. They are 2 sets of twins, and they had very similar issues in terms of having infection, respiratory distress, requiring CPAP, but they're now kind of on their way to recovery, fully established feeds, and they should be going home in the next about like 5 to 6 days. So this is on this side. We have a baby here who I'm just going to show you is a baby who was born at 26 weeks at 900 grams. This baby came in, delivered, the mother delivered the baby without any warnings. We rushed in the middle of the night. In fact, it was 4 a.m. in the morning when the entire team came in. We are always ready to handle such babies. The baby was delivered, appropriate care was given, and in fact was transported from the delivery unit to the neonatal intensive care by the entire team of doctors and nurses. This baby required a lot of work initially, so we had to give surfactant to help the lungs. Then the baby was actually in an incubator, which I'll show you later. The baby was cared for, and now this baby is actually about 30 weeks of warmer care. So this baby has had a very good outcome. We took all the measures that needed to ensure the safety of this baby. This is what happens when you actually take extreme precautions, provide appropriate care. In fact, what we provide is called a developmental care, which helps the baby grow, not only physically but also mentally. So this baby is currently on, as you can see, just a Optiflow. This baby is on its way to recovery, has had no neurological problems, no gut issues, no heart issues, and no infections. This baby is fully fed, as you can see, through the NG tube, to the orogastric tube. This baby has done extremely well and is putting on weight and is going to be here for some more time till we are ready for discharge. Was again born at 26 weeks and at 860 grams. Now this baby has been here for almost about 10 days now. This baby again was delivered in the middle of the night. Again, as usual, we were there for the delivery of this baby. Required surfactant administration. We in fact don't ventilate babies. As you can see, most of these babies are on CPAP. So the thing is, we do this to protect the lungs. The way forward is, especially for preterm care and especially for extreme preterms, is not for ventilating the babies and going on for CPAP, which basically ensures that the lungs are not damaged. They come out very well without any residual damage to the lungs. The brains are preserved. We don't do much interventions. The baby is cared for in this excellent state of the art incubator, which basically gives the same environment as what the mother would give, almost the same environment as what the mother would give in the womb. Humidity is maintained, temperature is maintained, and this baby now is putting on weight, is doing really well, has no issues as far as the head is concerned. So there are no intracranial bleeds, there is no PDA. In fact, this baby is well on its way to establishing feeds. Our time to achieve full feeds is almost like about 7 to 10 days. So in fact, this baby is about day 9, day 10, and is almost achieving full feeds. This helps them get discharged early, reduces the incidence of infection, reduces the incidence of complication. So this baby has no UAC, no UVC, no PICC lines, nothing. In fact, we're just giving no total parenteral nutrition. That has been stopped now, is only on full feeds. So it's well on its way to recovery now. So we usually monitor, we follow standard international protocols. We follow what has to be done in terms of the head scans, in terms of the echoes, to make sure that there's no PDA. We do the routine bloods, appropriate supplementation, appropriate nutrition, and frequent monitoring of the weight and the outcomes. In fact, this is what we also counsel the parents every day. We talk about how they're doing. In fact, the parents see the babies grow, and they are actually aware of what is happening with the babies. So every day the feedback is given to the parents about the condition of the babies. So this is one of the babies who is born at 26 weeks. And this baby was born at 25 plus 3, so even more smaller earlier than the previous baby I showed. And this baby was born at 600 grams. So you can see that this baby was very tiny, has been here almost for a month now, and is actually doing very well. This baby also again required a lot of work. As you can see, we do handle the very preterm babies. It doesn't mean that all the preterm babies end up with problems. This baby in fact has done fantastic despite being born at 25+3. Again, premature delivery, the parents just rushed into the hospital because the mother was having contractions. Baby was delivered, this time luckily in the daytime. But again, the whole team was there. We did whatever that was needed for the baby. Initial resuscitation management was done. Again, the baby was not ventilated for long, because preterm 600 grams, 25 weeks, no ventilation, surfactant given, CPAP was put on CPAP, appropriate nutrition was taken care of, total parenteral nutrition was started as per the ESPGHAN guidelines. We started early, we started appropriately, ensure the growth of the baby. This baby in fact has had very minimal complications and no PDAs, no infections, just has a small amount of bleed in the brain, but that is actually a grade 1 bleed which has no significance later on in life. As I said, this baby has been here for almost a month now, has put on very good weight and is doing brilliant for his age. So this baby is doing full feeds, and again, as you can see, that doesn't mean that all the preterm babies end up with problems. Parents initially had given up the hope. They said, see if you can do anything. If you can't do anything, let it go. But we said that we do handle extreme preterms. We have had successful outcomes with extreme preterms, and this is one example where the parents are very happy, and they are actually in a state of disbelief that actually a baby came out at 25 weeks, 600 grams, and has done very well. So this is the kind of babies that the level 3 unit, as a level 3 unit we manage. This baby is here, which is born at 28 weeks. So this is one of our more senior babies, had born at 28 weeks and is almost ready for discharge. Has got another 4-5 days left, and here basically what we see is this baby is fully fed, grown, and it's basically we are still giving the NG tube, and we are waiting for the baby's maturity so that we can start on Pallada feeds, which are going to do it in a couple of days. Once the baby is on Pallada feeds, we ask the parents to come in. The parents will feed the baby, the mother will feed the baby, the father will feed the baby with the Pallada. Once they are sure that everything is going fine, they are confident, and we then shift the babies down to the mother side, which is the postnatal ward, where they stay for a couple of days. They taught about resuscitation, they taught about how to take care of the baby, temperature regulations, and a further follow-up plan is given to them. And once they go home, we actively are in touch with them for the first couple of days. They come back for follow-up, and then we assess their weight. Once they are absolutely confident, we do weekly follow-ups. All these babies do very well if cared for appropriately in an appropriate center. So what I suggest is, being a level 3 unit, we can manage a lot of extreme preterm babies, less than 28 weeks, which should not be a problem for us. But what I request for all the doctors out there is, if you do have an extreme preterm baby who you suspect is going to deliver, please try to deliver them in a level 3 center, because the care provided is multidisciplinary. In fact, we have neurology input, cardiology input for these babies. We have a nutritionist giving input regarding the nutrition, ensuring the growth of the babies. Nurses are there 24/7. My nurses are extremely well trained, and they do a brilliant work with regards to these babies. And we have had, it's just not me saying, it's also that we have had excellent feedback from parents regarding the care that we provide. And it's my humble request is, if these babies are delivered in a level 3 unit, they do extremely well and will have extremely good outcomes. Thank you very much for listening.